And I will focus my presentation today mainly on the surgical and surgical issues and complications. As I said, I'm an oral surgeon. I will cover just the surgical part, just the surgical aspect. I will not cover any prosthodontics because it's not my field. So what is the all-on-4? Well, the idea was to come through with a technique where we use only 4 implants or 6 implants for a full mouth rehabilitation. This way we could avoid the bone grafting and bone transplants and so on. And also, with only 4 or 6 implants, we can avoid the posterior regions of the bone where we know that the bone is softer. With this technique, we tilt the posterior implants at a 45-degree angle. We use a fixed standard guide, which is malleable and which made of titanium, can be used in any arch. This way, by tilting the 45-degree posterior implants, we reduce the cantilever. We deliver on the same day a fixed provisional acrylic bridge with 10 or 12 teeth, depending on where the implants are coming out. And this technique can be done either with flap or flapless approach. Why? Why to do all-on-4? Well, if we go back during the 2001, several articles and several colleagues were trying and were writing about tilted implants. And for instance, as you can see here, 2000 and 2001, from this article, Boehringer and Zempellis, they ran some mechanical studies, some mechanical experience to measure the bone stress at the implant cervix. And what they did was they compare straight implants with tilted implants, and then they increased the cantilever. And instead of a straight implant with a big cantilever, they moved the posterior, the last implant for the tip of the cantilever. And also they compare the length of the implant, the difference between shorter or longer implants. And they came out to a conclusion that the stress in the bone is lower when we tilt the implants instead. On these findings and others, in 2003, the first all-on-4 article came out with clinical studies made just on the mandibles. So it was in 2003 when the first article came out. When do we do all-on-4 or all-on-6 in the maxilla? Let's start with the maxilla. Well, if we have full bone volume, meaning that our posterior implant will come out on the 6, okay, or even on the 7, if we have that amount of bone available, we think about all-on-6, okay, because this one is coming out either on the 6 or 7. So we have no cantilever or one tooth in cantilever. That's not very common to have full bone volume, but when we have it in a case like this one, situation like this one, as you can see, we have plenty of bone here, enough to place 6 straight implants. Good thickness, good amount of bone, although the anatomy doesn't look very well, but we can compensate that, and we go for 6 implants. And let me show you, this is the standard guide, which was developed for the all-on-4. Because if we joined this point there to that point there, we have 45 degrees. So this guide was developed for the position of the posterior implants and also to help us with the positioning of the posterior abutments. But I will show you that later on. But anyway, I also use it for the all-on-6 because I find it convenient and it helps me with the placement of the straight 6 implants, like in this case. 6 implants and the posterior ones are coming out on the 6. So we don't have any cantilever, or we have one tooth in cantilever. Now, when the anterior wall of the sinus comes forward, which are the most common frequent cases, then we can think about tilting the posterior implant, and then we go for all-on-4. And we go for all-on-4 if the posterior implant comes out between the 4 or the 6. This is the maximum cantilever acceptable. between 4 and 6. And for that, we need to have a bone crest with a minimum of 5 millimeters width and 8 millimeters height. So why is all this issue about the cantilever? Well, if you remember from the high school, the load that is produced on this structure, which you can call momentum, we can call it M, this M will be equal to the force which is applied to the cantilever times the distance. So imagine this distance and this load, this force, it's the momentum. It's the load which is transmitted to the structure. So if we reduce the cantilever, of course, we will reduce this distance, and of course, we will reduce the momentum. So it's very important for you to remember this from the high school. Sorry. Okay. And even today, you see these two articles are recent, 2018, 2019. What they suggest and they conclude that the optimal number of implants for a full mouth rehabilitation varies between 4 and 6. They don't need more than 6 implants for a full mouth rehabilitation. So how do you do it in the maxilla? Well, the protocol is quite straightforward, and please don't change the protocol. I know that the best things about protocols is that we can change them, but if you change them, please change them for better. Don't change them for worse. And what I mean is that this is the first step, which is opening the sinus, okay? Make a small opening on the external wall of the sinus in a way that we are able to see the membrane and push the membrane inward. I'm not saying to perforate the membrane. I'm saying to push the membrane inwards so we can introduce a probe. We can introduce a blend probe, and this way it's the only way, it's the best way for us to see where the anterior wall of the sinus is, because that will be our posterior, that will be our posterior limit of our surgical field. Our posterior implant should be right in front of the sinus, right in front of the anterior wall of the sinus. And for that, it's not the X-ray, it's not the surgeon skills. You have to open the sinus to see, to feel where the anterior wall is. After identifying the anterior wall, we place the guide, and this guide will give us the 45-degree angulation for placing the implant. So the guide, we use it at this stage and also when we are applying the posterior abutments. These are 30-degree abutments, and this rod of the abutment should come out either on the occlusal aspect or on the lingual or palatal aspect of the prosthesis. And for that, if we are parallel to the guide, we will ensure that we are coming out on the right place. So at the end of the day, what we want is this: 4 implants, 2 tilted ones at 45 degrees at the back, and 2 straight ones at the front with a bicortical anchorage when possible. We'll come to that later on. What about the mandible? Well, the mandible is more or less the same thing, except that when we have full bone volume, again, we go for 6 implants, of course. Like in this case, it was a lady with this treatment made 15 years ago in South Africa. And she came to us because this was removable. This was a removable rehabilitation. And as you can see, over implants and over teeth, and the teeth were showing some problems. So we were able to place an all-on-6 because we had full bone volume. And we went from this to this with 6 implants. And as you can see, the posterior ones are coming out on the 6. So we will have no cantilever or one tooth-in cantilever. When we don't have, so we went from this situation, this removable prosthesis that the patient had, to, in the same day of surgery, immediate provisional bridge with the posterior implants coming out on the 6, as you can see. So how will you do it the all-on-4? Well, if we don't have full bone volume, it's more or less the same as in the maxilla, except that now our posterior limit are the mental nerves. And we should identify and explore the mental nerves. Look at this slide. It's a very nice picture, I think, because we have 2 foramina. We have 2 sites for the nerve to come out. And don't forget also that we should explore the foramina or the foramen, because most of the time the nerve inside the mandible does a loop before coming out. So it's not the anterior wall, the anterior aspect of the foramen, which is our posterior limit. It's the loop of the mental nerve, if it's present. That is our posterior limit of our operating field. So if we have a crest that allows us to start above and behind the nerve, by tilting the implant 45 degrees, like we are doing here with this preparation. So starting above and behind, tilting 45 degrees, we'll be in front of the nerve. So we'll be safe, because with 45-degree angulation allow us to be in front of the nerve. And then again, we compensate that angulation with a 30-degree abutment, which should be placed with the help of the guide. So this is what we are looking for. As you can see, we start above and behind. So we reduce the cantilever and we are in front of the nerve. We are in a safe position in front of the nerve. What about atrophic mandible? Is there a point to do an all for an atrophic mandible? A situation like this. Both foraminas are at the crest. So we cannot start above or behind the nerve. We have to start in front of the nerve. So if we have to start in front of the nerve, why bother to tilt the implant? Well, remember that study with Boehringer in 2001? He concluded that the bone stress, it's lower if we use longer implants. And that's the only advantage of using an all-on-4 or tilted implants in an atrophic mandible, because we are starting in front of the nerve, like we will do if we use straight implants. As you can see here, we are in front of the nerve, but the only advantage is that in a crest, in a mandible like this, that the maximum height was 10 millimeters, I could use 13 millimeter implants. So longer implants, because I tilted the implant. So by tilting the 45 degrees implants, we can use longer implants. That's the only advantage of doing an all-on-4 in such an atrophic mandible. Provisionals. I said that I was not talking about prosthodontics, but at the end of the day, after surgery, we deliver a full acrylic provisional prosthesis fixed to the patient. That's the protocol. And this full acrylic bridge has 10 teeth or 12 teeth, depending on where the implants are coming out. So we can go from a situation like this one to a situation like this. This is 10 days post-op when we remove the stitches. And as you can see, we have 2 provisionals with 10 teeth only. So we reduce the cantilevers during the healing process, during the first period of healing, when we are using the provisionals. And this is the kind of provisions that we deliver on the day of surgery. So we can go from a situation like this to a situation like that on the same day. These are still provisionals. From this to that on the same day. The final rehabilitation. You know, a lot of people ask me, when do we go for the final rehabilitation? 4 months, 6 months, 8 months, when? Well, let me tell you my opinion about that. Nowadays, for the final rehabilitation, we always do a condylography according to the Slavicek technique. We have these tracings and we do the rehabilitation upon these findings, mainly if we are doing a bimaxillary case. Also, of course, you know that the final rehabilitation, it's the final bridge, it's over a titanium CAD/CAM structure. This structure should be passive. And to be passive, we have to try it. Please try it in mouth to make sure that the structure is passive. Also, check occlusion, of course. And after everything checked and upon our tracings and our findings with the condylography, we go for a final rehabilitation. And as I was saying, when do we go for that? Well, some people, they go after 6 months. I don't care about timing. I care about soft tissue management. And this, I believe, it applies not only for full mouth rehabilitations, but even for a single implant. It's the soft tissue that decides the time to go for the final rehabilitation. And only when I have this situation, only when I have a concavity against convexity, I go for the final rehabilitation. And this is produced by the provisional. This is produced by realigning the provision during the healing time. So what tells me to go for the final rehabilitation? It's the soft tissue. The soft tissue has to be worked in a way that we can have concavity on the tissue against convexity on the bridge. We don't want wings. We don't want acrylic extensions. Nothing of that. We want this to work perfectly fit. No space between. Okay, that's the best way. That's the best solution for the final rehabilitation. And the final rehabilitation can be an acrylic bridge that works very well, or can be ceramic or zirconia bridge, something like this that we can deliver above 4 implants or 6 implants. Situation like this. From this to that. This is an acrylic bridge, works very well. Most of my patients, they go for acrylic. From this to that. Now, let's start with the issues. 4 or 6, well, that depends on the amount of bone. As I told you before, if I have full bone volume, I go for 6. Look at this case, a huge crest, a lot of bone available. This is a gentleman in his 40s, big guy, big masseters, a lot of torque, a lot of force. And what happened? It was not an all 6, it was an all 4. So in my opinion, this is wrong. This situation, this patient with all this amount of bone and having in consideration his physical fitness and his age and the anatomy of the crest, of this crest, this should have been an all 6, not an all 4. Talking about anatomy, well, of course we have to follow the anatomy, but look, this is not what we want. Can you see, before surgery, the maxilla was flatter than after surgery. This is not what we want. We want a smooth, uniform surface with the implants all at the same level, okay? So of course we have to follow anatomy, and the anatomy can be tricky, as I will show you, but we can change, and we can prepare our bone in such a way that our implant should be at the same level. A case like this, we don't need to open such a big lingual flap. Be careful with lingual flaps. You know that behind this and below this, there are arteries, and there are the sublingual artery, the lingual artery, and those arteries, they can bleed blindless. We don't see it due to the gravity, and this can be life-threatening. So don't open that much. We just need to raise a small full thickness flap in this region, enough for us to place a probe to have an idea of the internal wall of the mandible. No need to raise the flap until the Jenny process, because that can bring you a lot of complications. And of course, anatomy, we have to follow the anatomy, and sometimes it can be tricky, because in a very flat maxilla like this one, these things can happen. Of course, this isn't acceptable, and of course, we will have to change the abutments for angulated abutments, but that is due to the anatomy. That's what we have. We cannot change it. Of course, in some cases, we can overcome some anatomical defects, but sometimes we have to follow, or most of the times we have to follow the anatomy. We can change anatomy. Of course, we can lift the sinus, or we can even lift the nasal floor, like I'm doing here. As you can see, I have 6 millimeters height, so I can change it by grafting and by lifting the nasal floor, and be able to place a 10 millimeter implant. It's very easy. It's easier than the sinus, because the membrane is thicker, as you can see here. It's very easy to lift the nasal floor membrane. And what I do is I do my preparation, making sure that I perforate the nasal floor, and then I will place my graft. Of course, the graft material, it's up to you. In this case, I will use only tricalcium phosphate from a Portuguese manufacturer, and I start placing the material through my preparation. Okay, I push it up, all the way up, in a way that when the implant goes in, the implant will push all this material towards the nasal floor. Of course, I also fill the nasal floor. I will place my graft also on the nasal floor, enough to build a layer or a barrier between the tip of the implant and the nasal floor. Of course, part of this or all of this graft will be resorbed or replaced by bone. And if you can have a small or a thin layer between the tip of the implant and the floor of the nose, it's more than enough. We are talking about we lifted this nasal floor for 4 millimeters. So if at the end of the day we get 2 or 3 millimeters, it's more than enough. So anatomy, we can, in some cases, sometimes you can change it, you can make it better. Now, proprioception, as you saw in the previous slide, sometimes we leave some teeth behind, mainly some molars, the 7s or even the 8s, if they are okay. And that is due to 2 things. First, it can help us with the vertical dimension. As you can see there, if we have one up and one lower, that will help us with the vertical dimension, but for sure, it will help the patient with the proprioception, because otherwise he loses all the guidance. Keeping 1 or 2 teeth, it will help the patient with the proprioception of knowing where to close, how much they can bite, all those issues that proprioception gives us. And we can keep these teeth during the healing period, during the provisional period, or we can keep them also after the final rehabilitation. Now, bone reduction. I know this is an issue that some of you don't like, because nowadays we talk on the other way, on the opposite direction. We talk about bone augmentation. But remember that mainly due to these 2 points, due to the smile line and due to the lip support, in most of the cases, we need to do bone reduction. For instance, the smile line, as you know, we have 2 kinds of smile line. We have the gummy smile, the eye smile line, or we have the low smile line, where the patient doesn't show any gingiva when he smiles. If we have eye smile line, the so-called gummy smile, we can deal with that in 2 different ways. For instance, situation like this one. When the patient smiles, we can see a lot of gum. So we can solve that by doing a bridge with natural gingiva. In this situation, we don't need to do any bone reduction. So we don't touch the bone. But as you know, it is very difficult to maintain this aesthetic outcome towards the time. And surgically, it's very demanding, because implants, they have to come out on the right position. They cannot come out on the papilla. They have to come out on the right position of the tooth. So we can with the provisional, we can have this situation. We can work the soft tissues in order to achieve nice contour, in order to achieve this kind of papillar contour, but that is very difficult to keep during the time. And in this kind of situations, it's the only time that I can consider flapless surgery, because we are not touching nothing. We are not reducing the gum, and we are not reducing bone. We are not touching. So that's the time to use a flap approach. Or we can go for a bridge with false gingiva. Okay, so if you go for a bridge with false gingiva, of course we have to do bone reduction, because the implants, they have to be placed in a more higher position to uncover the transition zone between the natural and the false gingiva. Okay, so for that, we need to do bone reduction. So we have these 2 choices: either don't touch the bone and keep the natural gingiva, or false gingiva, and for that, we need to reduce bone. Otherwise, the transition zone can be noticeable. For instance, a case like this one, of course we have to reduce bone, and we have to reduce bone on the upper and lower. Otherwise, we'll not be able to uncover these transition zone of these patients. As you can see here, look the amount of bone that I had to cut. You see on the X-ray on the right side, you can see that I cut the bone almost through the floor of the sinus on both sides. I couldn't cut anymore, okay? So this is the amount of bone that we need to reduce in order to solve cases like this one. And these are the provisionals on the same day. Final rehabilitation. From this to this. Of course, we need to reduce bone. Otherwise, we cannot uncover the transition zone. Another case, another gummy smile. So when the patient smiles, we can see the gum. Of course, we need to reduce bone. And when I say reducing bone, sometimes it's this amount of bone. It's quite huge, quite a lot. And I always do it this way. First, I start with one side. I know I've measured before. I know how much bone I need to reduce. So I reduce on one side, and then I go to the other side. If you do it straightforward, if you do it at the same time, both sides at the same time, you lose your reference. You don't know how much bone you are reducing. So please reduce one side first, and then go to the other one, the other side. And as you can see, this is a pre-op X-ray and post-op X-ray. Look how much bone we had to reduce in order to uncover this gum, in order to make sure that when the patient smiles, you don't see the transition zone between the prosthesis, between the false gingiva, and between the natural gingiva. This is absolutely unacceptable. And this happens because the bone reduction was not enough. This happens because the implants should have been placed in a more higher position. If the implants were in a more higher position, the transition zone, when the patient does this, when the patient smiles, it's not noticeable. So this is not a lab problem. This is not the fault of the lab. This is a surgical problem. This is a surgical issue because during surgery, we didn't reduce enough bone. Sometimes, I'm sure that it happens to you also, I get X-rays by email. For instance, like this one. When I saw this X-ray, I thought, well, this is an all-on-6 for sure. After seeing the patient, look, it was an all-on-4 because I had to reduce a lot of bone due to the gummy smile. So please don't go just with your X-rays. You have to see the patient before you decide, and please make sure that you see the transition zone, that you see the smile of the patient, that you look to the patient before surgery. This should be done all before surgery. Cases like this, I call this orthodontic surgery with implants. Of course, we have to reduce bone. If this patient was going for an orthodontic surgery, he will do a 4-1 and a bilateral segmental surgery for the mandible. Of course, it will reduce bone also with orthodontic surgery. So if you are not applying orthodontic surgery, we have to reduce bone in order to be able to place our implants, which should be placed in a more higher position. So we have space enough to build our prosthesis, and we have space enough to uncover the transition zone from this to this. For that, we need to reduce bone. On the other hand, if we have a low smile line, if when the patient smiles, you don't see the transition zone, no worries. There's no need to reduce bone. There's no need to touch because it will not be noticeable. Another issue is the lip support. You know, with time, with the loss of natural dentition, with bone resorption, we have lack of lip support. So what we have to do? Bone reduction. Look at this case. Again, I reduced as much as I could. Can you see? Those are the nasal floors. I couldn't cut any more bone, but anyway, this is the result. Okay, and this angle between the bone and the gum and the prosthesis should not be more than 45 degrees. If this is more than 45 degrees, it will be very difficult for the patient to wear. It will be very difficult for the patient to keep it clean, and it will be very uncomfortable. But anyway, in this case, maybe I should have placed my implants a little bit more higher, but I couldn't. I couldn't because I didn't have more bone to cut. So I'm not more than 45 degrees, but I'm in the limit. But anyway, the patient is able to keep everything clean, and it's happy with the solution. And we were able to uncover the transition zone on one aspect, and on the other aspect to bring the lip forward. So the prosthesis is bringing the lip forward, it's giving lip support, and that it's possible due to the bone reduction that we have to do during surgery. Another case, look at this case. How we are going to correct this? Of course, we have to place the implants higher so we can gain space for the prosthesis, and we can gain space for the lip support. So we can go from this to this on the same day, from this to this. But for that, of course, we need to reduce bone. Of course, we need to place our implants in a higher position, in a much higher position. From this to this on the same day, after bone reduction, of course. Implant length. Well, we spoke a little bit about implant length according to those findings of Boehringer, but there are situations where we need long implants. When I'm talking about long implants, I'm talking about 18s, 20s, well, 22. It's not 16s or 15s. 16s or 15s for me are standard implants. 18s, 20s are long implants. And why do we need long implants? Well, as you saw now, most of the times, most of the cases, we have to cut bone. When we cut bone, we lose one of the corticals. So we will not have bicortical anchorage, which is the best way to anchor our implants. So we need to reach at least one cortical. And the cortical that it's left for this kind of approach, it's the nasal floor cortical. But in some patients, to reach the nasal cortical, we need long implants. And this is even more important if we are dealing with soft tissue. If we are dealing with soft bone, because in soft bone, our implants, the tip of our implant has to find the cortical. We cannot leave our implants on the medulla because otherwise we don't have enough stability. So sometimes in order to be able to do this kind of situation, to reach the nasal cortical, we need long implants in the region of the 18 or 20 millimeter implant. Internal, external, well, I've tried all, it's up to you. I've tried trilobe, I've tried internal X, external X. Nowadays I'm using more internal X. What I don't recommend is the trilobe, because as you know, with the trilobe we have to leave one of that triangle pointing towards you, pointing towards the external aspect of the bone. So it's the implant who decides where to stay, and that's not all right. I prefer to be me to decide where to leave the implant. I like to leave the implant where I find good stability, good primary anchorage. And good primary anchorage for me, it's between 45, 50 newtons. Above 50 newtons, that's the best to load the implant. Okay, so internal, external, X. I have several cases with internal, I have several cases with external, and as I said before, nowadays I'm using more internal connection. Bone defects. Well, of course, most of the times we deal with bone defects, mainly when we have extractions. In a case like this, most of my cases, we have extractions to do, of course. So after extractions, sometimes we have to deal with bone defects. A case like this one, there's a big lesion. We have two cystic cavities related with this canine. That's not the sinus, that's the second cavity, okay? I will show you that that is not the sinus because I will open the sinus, as the protocol says. We have plenty of bone, so we can keep some bone to regenerate this region. And there we go, we are opening the sinus, okay? As you can see, there is the membrane. Don't perforate the membrane, just check where the anterior wall is. So, as you can see, the lesion is right on the path of my posterior implant. So I have to go through the lesion. And again, sometimes we need longer implants to do so. Sometimes to go through lesions, 16 or 17 length implants are not enough. We need 18s or 20s. As in this case, I'm using an 18 implant. So 45 degrees through the lesion. And when I say through the lesion, meaning that the tip of the implant should be above the lesion. We have to overcome the lesion. Don't leave the tip of the implant on the lesion, because otherwise you don't get good primary anchorage. You don't get good stability. Don't leave the implant there. Okay, you have to overcome the lesion. And after placing the implant, of course, we'll graft this region with the bone that we have available. Other situations are impacted teeth. Sometimes the teeth, canines, like in this case, are impacted right on the path of our implant. You see, we did all the extractions, and now we have the canine right on the path of our implant. Can you see the bone defect? So we smooth the surface, we regularize it in order to reach a nice surface. Sorry, I think I'm having some problems because it stopped right. Okay, there we go. Okay, I'm one slide ahead of you. Okay, good. And then, as you can see, we were able to place the implant behind the defect. We're very lucky because we had a good thick crest, so we were able to place the implant not through the lesion, not through the cavity of the canine, but behind the lesion. Okay, as you can see here, not yet, but you will see, I hope. Yes, as you can see here, the implant is behind that bone defect. We compensate the angulation with the 30-degree abutment, as I showed you before. And for that, we use the guide again, remember. And at the end, we can graft and we can regenerate this region with bone, since we have a lot of bone available while doing this kind of approach. Sorry, I think there is a small gap between my slides and your slides. I will do it slow, a little bit slower. This is the X-ray, as you can see, right in front of the anterior wall of the sinus. Okay, please have in mind that to do that, to make sure that you are right in front of the anterior wall, you have to open it. You have to open the sinus. Situations like this. I got this patient from a colleague. I don't know, I cannot understand the position of these implants. As you can see, the patient has 3 implants with some bone resorption already, and 1 implant in the tuberosity in such a way that it was not possible to use it. So we decided to remove everything and redo everything again, because on the CT scan, you can see, sorry, we have to wait. We can see that we still have enough bone structure to do standard oral for even after removing all these implants. So that's what we did. We removed the implant, and although we have a lot of bone defects, as you can see here, mainly in the anterior region, at the back we can see the lesion of the pterygoid implant that was there. But anyway, we still have good bone available to do a standard procedure, to do a standard oral for. So we placed the 3 implants, and now we go for the anterior one, which is very close to that defect. And for this, I used bioactive Alfa gate 3.5 implant. It's a very, I like this implant very much because apart from being coated with the calcium phosphate, as you can see, due to the shape of the implant, to the anatomy of the implant allowed to do some bone expansion. It works as an osteotome. So even on a very thin crest like this one, as you can see, this is a 2mm drill. We have what? We have 1mm left. The implant, 3.5 implant, will expand the bone. It will expand the bony walls. This system, as I will show you later on, the drills are step drills, which is very convenient to make sure that the drill is on the right place. But I will show you that later on. I like to place my implants first with the machine, but most of the times I place my implants by hand. And there you can see another property, which is hydrophilic characteristic of these implants. These implants, once they touch blood, they attract blood because they are hydrophilic. And now you see the bony expansion. So, and this bony expansion, this bony wall expansion, it's due to the shape and to the anatomy of the implant. Well, sometimes we have, and a lot of times we have over-limit cases. And over-limit cases, I mean cases that we don't have that rule of the 5 width and 8 length bone available. So we have to think how to do All-on-4 on these cases, on these situations. Well, one of the solutions is go through the sinus. Place a situation like this one. You see, we have on the left side, if we are going for a standard procedure, tilting the implant 45 degrees, the screw or the abutment will come out on the canine, which is not acceptable because we're going to have a big cantilever. So in order to implant coming out on the 5 or on the 6, we can go through the sinus in a situation like this because we have a good external nasal wall. So we will point to that wall, and again, so we lift the sinus, and with a 20 millimeter implant, we can reach the nasal floor and get anchorage to the nasal floor going through the sinus. Then we graft, and we compensate the tilting of the implant with the 30-degree abutment. Hybrid solution, we mean we use standard parts and other kind of implants. Cases like these. Of course, you'll say, well, very nice case for a sinus graft. Yes, it is. Very, very nice case for a sinus lift. I love these septums. As you can see there, mainly on the right, there's a very nice septum on the sinus, which allow us to divide the sinus in compartments, and it's very easy to graft and to lift this kind of sinus. But patient didn't want to do several procedures, so we decided to go for a hybrid solution. And hybrid solution meaning that we use 2 straight implants at the front and 2 zygomatic implants at the back. These are not zygomatic implants, as I will explain you. These are extraoral implants. I'll come to that later. And as you can see, we have normal, let's say, cantilever, because the screws are coming out on the 4 and on the 5. So not a big deal with the cantilever, and we were able to deliver fixed rehabilitation to the patient using 2 zygomatic or 2 extramaxillary implants and 2 straight ones at the front. Now, talking about zygomatic implants, I'm not very keen on zygomatic implants. There are studies showing more than 90% success rate with zygomatic implants, but this is a technique for me, in my opinion, that if you only get 6 or 8 cases per year, you'll never be good at it. If you get 60 or 70, yes, you're going to be good at it. But I don't get that much cases that needed zygomatic implants. And as I was saying, these are not zygomatic implants. These are called extramaxillary implants because, as you can see, the zygomatic implants, as they were described initially, they were going through the sinus. The problem is that by going through the sinus, the abutment, lateral aspect of the patient. So in order for the abutment to come out on the crest, like in this one, as you can see on the right side, we go outside the sinus. So we remove, 2 zygomatic implants, which actually are not zygomatic implants, are extramaxillary implants. But as you will see, we have some complications with this kind of implants. And as I said before, I try to avoid them. Nowadays, we also have, we are able to do All-on-4, All-on-6 with custom implants. Custom implants, for instance, like these ones that were presented in 2016, laser melting implants, or 3D implants made with the titanium powder. Well, the point is that the implants are made. The implant is made to the patient. Okay, it's a standard custom implant made for the patient according to the CT scan or the CBCT, and that's a problem because we have to think that sometimes we have some discrepancies on the CT scan readings. So situations like this one, look at this case. If you see the measures on my left side there, I had 6 millimeters height. Then at the front, I had 7 millimeters, as you can see. In the middle, I have around 5 or 6 millimeters on both sides. And on the left side, again, 6 millimeters there and 7 millimeters at the back. So instead of short implants, we decided to use custom implant. Of course, we could go for short implants, and if you have experience with short implants, go for short implants. But we can also think about a custom implant. A custom implant can be something like this. It's an all-4 with a custom implant which is made for the patient. They with this 3D software, they have the ability to see where the patient has the most bone in order to place the screws. So they decided the best place to screw the implant to the remaining bone, and with screws ranging from 9 to 11 millimeters length, we are able to fix this custom implant to the remaining bone. And the implant can be designed as you wish. Can be 1-piece implant or can be 2 pieces implant. So what we do, a normal full thickness flap. Of course, we have to go back to the tuberosity, so this has to be longer than a normal flap, and try to keep the buccal fat pad in place, because otherwise it will interfere with your operation field. The manufacturer sends us a guide like this, to make some bone indentations, and those indentations are on the place that the abutments will stay. That's tricky, because sometimes, and most of the times, these are patients with very low bone available, and it's very easy to produce a iatrogenic sinus communication, because we are removing what is left of the bone, and the sinus is just there, so we can easily make an iatrogenic communication which can become chronic, that I'll show you later on. So this is the implant. This is the 1-piece implant. As I said, you can choose 1 piece or 2 pieces implant. And now let me show you, although this is a titanium implant, which is hard, of course, it allows for some flexibility. As you can see, the implant has to be passive. The implant has to be in perfect contact with the bone. And as you can see now that I'm tightening the screw, there is a little bit of flexibility, which we'll see even better now, because this part of the implant, when we tighten the screw, it's able to bend. And by bending, it will be, as you can see now, you see, we can bend a little bit the implant, and this way we make sure that we'll be in perfect contact with the bone. Also here on the palate, you'll see that the implant allows us to have some flexibility, and that flexibility will be very important to be sure that we are in perfect contact between the implant and the bone. So I usually use this screw to place this key to place the screws, but after that I always check by hand if the screws are well tightening, and I always check if there's no gaps between the screws and the implant and the bone. If there is a gap, please fill it with any graft material, bone, or whatever you like. But this is very important. The implant should be, the custom implants, they have to be in perfect contact with bone, no gaps between, because they can break, as I will show you. So after we place the implant, after we screw the implant, we place the abutments, like the multi-unit abutments, like in a normal all-on-4 case, caps, and we close. And this is the post-op X-ray. Immediate provisional bridge, and 10 days after surgery, you can see a very good keratinized tissue around the abutments. So it's a good solution for very atrophic cases. Of course, this is, as all techniques, this is recommended for very atrophic cases. This is not for a standard, this doesn't substitute standard all-on-4. Okay, this is just for when we don't have bone. This is I can say that the custom implants can replace the zygomatic implants, in my opinion. Complications, well, complications can start even before surgery, of course. If, as we spoke before, regarding with the smile and the lip support. But of course, when we are dealing with so many screws, we can have complications with the screws. Like, for instance, this is a very recent article. They compare long and wide screws with narrow and short, and of course, long and wide screws gave us advantage in stress distribution in this kind of situation. Of course, we can have early complications like this one. As you can see on the right X-ray, one of the abutments is not well connected. And this is why, because we didn't took an X-ray immediately after surgery, just took the X-ray with the provisional already in mouth. So now we have to redo the provisional and tighten that multi-unit abutment, which is not well tightened. Check passivity of the bar. The bar has to be passive. This is not passive, so please check it. This is what I was telling you regarding custom implants. You see, this is not perfect fit. And this can be due to that discrepancy that I spoke about before of the CT scan. Because the measurements or the 3D readings from the CT scan sometimes can be accurate. And if they are not accurate, if they are not right, when we place the implant, when we sit the implant on bone, sometimes we have these gaps. And these gaps can be a problem because these implants can break. If the titanium bar can break, imagine a thin structure like this one. Of course, it can break, and I will show you that it breaks. A situation like this, we are talking about complication. Very nice X-ray for an all-on-4. That's what we did. And suddenly, this implant starts moving, starts migrating until it disappears. Well, if you see well, it didn't disappear. Can you see that? That's not a nasal piercing. That's our implant on the floor of the nose. As you can see it there, and as you can see it there. Okay? So the implant migrated to the floor of the nose. There it is, quite in a back position. So, I don't like to interfere with other specialties, mainly ENT surgeon or ophthalmic surgeons. I don't like to go to their field. But here we are in the limit. This is my field, this is maxilla, and this is the nasal floor of the nose. This is the nasal floor. So I'm on the limit. So my idea was to open a small window through the palate, reach the implant, and push it forward. So I decided to do so. And on the day of surgery, we took another CBCT before surgery, and the implant was not there. Luckily, the implant was not there. So we checked the surrounding structures to see if the implant was on any surrounding structure. It was not. So we conclude that the implant was either aspirated or swollen. As you know, when we think about it, we have to do a chest X-ray. The most probably position will be on the right side due to the vertical anatomy of the right bronchi. And of course, an abdominal X-ray to see if the implant was able to overcome all the curves and twists of the abdominal cavity. And it was everything clean. So we were lucky that the patient either swallowed the implant. Look at the situation. This is an article for 2017. It's quite recent. Exocular muscle damage due to a zygomatic implant. And you know, the rim of the orbit, the orbital rim, we can fix it either with a bone graft or a titanium mesh, but the lesion to the muscle, even after healing, we cannot fix it. It will be a permanent lesion. And these muscles, as you know, these exocular muscles, they have a very important role on eye positioning and, of course, on the vision of the patient. And this can be affected, this can be disturbed by a zygomatic implant like this one. And you see, very important issue. This was published not on a dental journal, this was published on the American Journal of Ophthalmology. So we are getting in trouble with ophthalmic surgeons. I don't want that. I try to avoid it at all cost. Late complications. Of course, again, screws can be a complication on a late stage. And if we don't have maintenance, of course, we can have surprises. Look, this patient, he was away for almost 10 years. And 10 years after the final rehabilitation, he came to us saying that he was feeling some strange taste and strange smell from the surgery site. Of course it was, because these two implants were completely lost. When we removed the prosthesis, they just came out. Another case, 5 or 6 years after surgery, after position of the final rehabilitation, we lost one implant. Now, in these cases, when we lose an implant like this, the first thing that I try to do, for instance, in this case, these were 4.2 implants. I tried to place a 4.7 immediately. You know, when I first came across the 4.7 implants, I said, why? I have 4.2, I have 5, why do I need a 4.7? And nowadays I use a lot of 4.7s, mainly in these situations. When I lose an implant, I can remove a 4.2 and place immediately 4.7. If not, we wait, we reduce the cantilever, we wait for the healing process, and then we replace the implant. Another case with no maintenance for 8 years with a provisional. You see, this is a provisional. And another one saying that, oh, I have a strange feeling, I have a strange smell. Of course, yes. These two implants just came out with the prosthesis. No maintenance. Of course, this can be also related with the roughness of the surface. That's another issue. Okay, but this protocol, this rehabilitation technique needs maintenance, and you should have a straight maintenance protocol. Another problem, sometimes we don't have keratinized tissue around the abutments, and these should be seen during surgery. When we are closing, we must be right that we have enough keratinized tissue around the implant, around the abutment, because it's much easier to graft right at that point. We have everything open, we have plenty of soft tissue, so we can grab a little bit of soft tissue from the palate and do a graft immediately. Otherwise, we have to do it later on. So we can go to the palate. The palate, it's a big friend of us, and we can make a soft tissue graft around the implant in order to increase the keratinized tissue around the abutment. Other complications, as I told you, these custom implants, they can fracture. You don't see the fracture here on the X-ray, but I guarantee you on the right side, this implant was mobile. It has mobility. So we removed the implant and we decided that we still have enough bone for a standard all-on 4, meaning that this shouldn't be done. Okay, so the colleague who did this rehabilitation with this kind of implant, there was no need, because it was possible to do a standard all-on 4, as you will see. So we removed the implant, the standard implant, and now, can you see there at the back? Look what we have. Iatrogenic sinus communications. So remove all the implant, all the screws, everything. So the fracture was this one and this one, okay? And now we have this situation. 2 chronic sinus communications. So luckily they are in a position far back, so we can place our implants in front of those communications. And for that I used Alfa gate implants. Again, because they give me very good stability. As you can see here, I'm applying more than 50 newtons. As you can see, I'm using the guide to guide me in my 45 degrees. And again, these implants at the back, there was no problem because I have a good thick bone, but in the front, again, these implants will work as osteotomes. These implants will make bone expansion. They will expand the bony walls. So remember the guide for the posterior implants, the guide for the posterior abutments. For the anterior ones, we don't need. Of course, I checked to see if there was any threads exposed. There was not. And for the anterior implants, we don't need that titanium guide. We just need the pin rod. Okay. So with the 2 millimeter, we will decide how to use the other drills. This is, for me, the best and the only way to see and to feel what kind of bone we are dealing with. If it's hard, if it's soft, it's what kind of bone we are dealing with. You can do the amount of tests that you want. The 2 millimeter drill, it's the best way to feel and to see the quality of bone that we are dealing with. As I said before, this system, the drills are step drills, meaning that you see the tip of the drill is the same diameter of the previous one. So it's very easy to place the drills on the right position, on the right place. So we will keep the parallelism of the preparation by using these step drills. And as I said before also, I like to finish my implant by hand, the position of my implant by hand. As you can see, again, the hydrophilic property, the implant is already attracting blood, and I'm applying more than 50 newtons for sure. Okay, so the anterior implants placed, and then we go for the abutments. For the abutments, for the posterior ones, again, we will use the guide. The anterior ones are just straight multi-unit abutments. We don't need the guide. Okay, and we have to choose the length of the abutment in such a way that all the abutments should be at the same level. Okay, so the guide for the posterior ones, again, this rod of the abutment should come out either on the occlusal or on the inner aspect of the prosthesis. And for that, the guide is very convenient. And then we will close these two chronic communications with fixed resorbable membranes, as you can see here. But anyway, 1 month after, we were not able to close the communication on the right side. So this has become a chronic communication, and so we decided to go for a palatal rotation flap, bringing the artery with the flap, rotate it towards the communication, suture it, and leaving the donor side healing by second intention. Of course, that's the part that gives more problems. So to avoid symptoms, we used PRF membranes. And as you can see, this is 10 days after surgery, the communication is close. So from this to that with the rotation flap. So this is another complication that can happen, which is chronic sinus communications. Sinus communications can be chronic for years. Look at this. This is a nice rehabilitation, but look, there's a big gap there and there's a big gap there. Why? Look at the gap. Big gaps on both sides. You see, there's a big gap there and there's a big gap there. This is a zygomatic case. The patient lost one zygomatic implant already on this side, and she still has this one on this side. And this case has more than 15 years now. And I can guarantee you, both these communications, they have 15 years now. I tried to close them once. I was not able to close them. Other colleagues tried to close them. They were not able. So this patient lives with this rehabilitation with two chronic sinus communications due to zygomatic implants. So we are coming towards the end, and my message to you is please keep it simple. This is not my case. As you can see, this is from Dr. Google. 5 implants. Well, again, Bo Renger, in those articles published in 2001, he proved that when we apply the momentum, when we apply the force or the load to this structure, 90% of that momentum will be taken by this implant downwards, and 10% of that will be taken by this one, 10% upwards. This one is getting nothing. This one is just compromising the blood supply of the others. So, and as you can see, this case with 5 implants in front of the nerve. Don't you agree that 4 implants with tilted posterior ones will be better, even to reduce the cantilever with this amount of bone available? I think so. Another case, another 5 implants. Again, the middle one is doing nothing. And still 5 implants and 2 big cantilevers. We could reduce that with 4 implants by tilting the posterior ones, as you can see. And look, this is not what we are talking about. And this is for sure a mistake, because they didn't open the sinus wall. You see, this is what, 4 or 5 millimeters. Remember that momentum calculation? If we reduce this 4 millimeters, if this implant was in front of the sinus as it should be, the cantilever will reduce drastically on both sides. Okay, so this is not what we are talking about. This implant is 45 degrees, okay, but it should be there. And this one should have been there in front of the sinus, not 4 millimeters in front of the sinus. This is also not what we're talking about. These implants were not correct. The angulation of the implants were not corrected with the angulated abutment. And this is definitely not what you're talking about. And look, all on 6, but the final one coming out on the 5. That's not what we are talking about. This implant should come out there. No cantilever. And in this case, there was no need for this. No cantilever, or at least 1 tooth in cantilever. You see the prosthesis, very nice provisional or final, I don't know. But 6 implants, the final one coming out on the 5. No, this one should come out there, even in a case with bone available. And in this case, I will not comment. 8 implants, 4 zygomatic, 2 pterygoid, 2 straight. Sorry, but in my opinion, this is over-treatment. This is not correct. This is not acceptable. And I usually like to finish this kind of presentations with this final slide. This is not Photoshop. This is true. I had this X-ray in my hand back in 2002. Remember, we are talking about all on 4, all on 6. We are not talking about all on 40. If you count the number of implants in this X-ray, they are 40. 3 per molar upper, 2 per molar lower, and an implant per root. 40 implants, okay? This is not definitely what we are talking about. Finally, I'd like to invite you to come to our formation center in the Azores and in the near future also in Lisbon, where our goal, our aim is to combine science with life surgery and life prosthodontics, combine it with nature and combine it with fun. So together with AlphaGate, we run 3-day courses where we go from A to Z with life surgery and life prosthodontics, covering everything from all on 4 or single implant, small bridges, you choose. So thank you very much for your attention, and I'll be more than happy to try to answer any question that you might have, that you can place it directly now, or you can send it to me later on by email. Thank you. Thank you very much for your time and for your attention.